Imagine walking into a hospital ward where the night shift never really ended. Beds line the halls, supplies are rationed, a bell rings from one patient while another needs oxygen, and somewhere across town, the nurses who should be arriving to relieve you simply do not exist. That was nursing in the 1940s, a profession caught between old rules and modern medicine, carrying the weight of a world at war. The decade transformed nursing, but it did so the hard way. Nurses worked through military emergencies, civilian shortages, epidemic disease, discrimination, and technology that advanced faster than hospital staffing could keep up. They were expected to be endlessly capable, calmly feminine, and almost superhuman. They were not supposed to complain. The first hurdle was sheer numbers. When the United States entered World War II, military hospitals needed tens of thousands of nurses. Civilian hospitals needed them too. The same communities supplying nurses to the armed forces were still dealing with childbirth, surgery, workplace injuries, tuberculosis, and outbreaks of infectious disease at home. More than 59,000 American nurses eventually served in the Army Nurse Corps during the war. They worked in field hospitals, evacuation hospitals, hospital ships, trains, and aircraft. But the rapid expansion created chaos. At Pearl Harbor, medical teams faced hundreds of casualties at once. Official Army histories describe shortages of instruments, sutures, sterile supplies, and protective equipment. Scissors moved from one operating table to another. Cleaning rags became face masks. Some operations were performed without gloves. That is not the romantic picture shown on a recruiting poster. It is improvisation under pressure, with a human life attached to every decision. The danger followed nurses overseas. They served closer to combat than any previous generation of American military nurses. Bombing, rough transport, tropical disease, extreme weather, and exhaustion became part of the job. Flight nurses cared for badly wounded patients in noisy aircraft, often without a doctor aboard. They had to recognize shock, control bleeding, manage pain, and make independent judgments while the plane vibrated around them. In the Pacific, 67 Army nurses were captured in the Philippines and held by Japan for nearly 3 years. By liberation, many were suffering from malnutrition and beriberi. Their survival later became a symbol of nursing courage, but courage did not make captivity less brutal. Back home, the shortage stretched shifts beyond reasonable limits. Cadet Nurse Corps graduate Marjorie Patak later remembered being told that no one was available to relieve her, so one full shift simply ran into the next. Nurses became ill. Some left hospital care depended on people working beyond the point when their own health was secure. Congress responded in 1943 with the Bolton Act, creating the United States Cadet Nurse Corps. The federal government paid for training, room, board, uniforms, and small stipends. Schools compressed nursing education into about 30 months, and students pledged to serve in military or essential civilian roles for the duration of the war. The program was enormous. More than 120,000 nurses graduated before it closed in 1948, and senior cadets helped staff hospitals while still completing their education. It eased the crisis, but acceleration carried its own burden. Students had to absorb medicine, surgery, obstetrics, and pediatrics quickly, then step into wards where experienced staff were already depleted. The second hurdle was disease. Today, antibiotics, disposable gloves, powered ventilators, and vaccines are so familiar that it is easy to forget how different a 1940s ward could be. Penicillin began reaching wartime patients in meaningful quantities during the decade, but it was new, scarce at first, and not a cure for everything. Streptomycin offered the first effective antibiotic treatment against tuberculosis in the mid-1940s, yet sanatorium routines remained demanding, and exposure remained frightening. Tuberculosis nurses managed isolation, sputum, nutrition, hygiene, wounds, and the emotional life of patients who might remain separated from family for months or years. Much of that work was intimate and repetitive. It also placed nurses close to an airborne disease before modern infection control systems and effective drug combinations became standard. Polio created a different kind of crisis. Major epidemics struck during the 1940s, and some patients lost the muscle power needed to breathe. An iron lung could keep them alive by changing air pressure around the body, but it did not eliminate the need for nursing. A patient enclosed in a metal cylinder still needed feeding, skincare, hygiene, reassurance, observation, and emergency help. If the electricity failed, caregivers might have to operate the machine by hand. Nurses also treated burns, trauma, psychiatric illness, and infections at a scale that pushed the boundaries of training. 1 out of every 12 patients admitted to Army hospitals received psychiatric care. The Army created a short specialist program for nurses, but demand outpaced preparation. Emotional injury was real. The language and resources available to treat it were limited. The third hurdle was status. Nursing required skill and judgment, yet nurses often worked inside rigid hierarchies built around physicians and military officers. At the start of the war, Army nurses held relative rank rather than full commission status. Their authority could be essential in practice and incomplete on paper. Full military commissions, equal pay, allowances, and retirement privileges arrived only in 1944. Civilian nursing carried its own contradiction. Hospitals called nurses indispensable while wages, hours, housing rules, and workplace control often reflected the belief that nursing was a feminine duty rather than skilled labor. Many hospital schools expected students to provide a large share of the workforce. Discipline extended beyond the ward into dormitories and personal life. Marriage could interrupt a career. In the Army, rules initially excluded married women and women over 30 before wartime need force some restrictions to loosen. Men faced a different barrier. Nursing was treated so thoroughly as women's work that male nurses were excluded from the Army and Navy Nurse Corps during the war. Gender stereotypes harmed everyone. Women were denied authority because their work was supposedly natural caregiving, while men were denied entry because caregiving was supposedly not masculine. For black nurses, the obstacles were harsher still. The Army was segregated. Thousands of qualified black nurses were ready to serve, yet quotas kept most of them out. In 1943, the Army limited black nurses in the Nurse Corps to 160. Although political pressure helped end the quota in 1944, only 479 black nurses were serving in a corps of roughly 50,000 when the war ended. Those admitted served in segregated facilities and were often limited to caring for black troops or German prisoners of war. The insult was obvious. A nation fighting racist dictatorship abroad was restricting its own trained nurses by race at home. The Cadet Nurse Corps officially prohibited discrimination based on race or religion, but many nursing schools still rejected applicants of color. Black nursing leaders, especially Mabel Keaton Stopers and the National Association of Colored Graduate Nurses, fought publicly against those barriers. Japanese American women also encountered rejection, including women trying to enter nursing after incarceration in wartime camps. This was not a side issue in nursing history. It shaped who was allowed to train, who was hired, where a nurse could work, which patients she could treat, and whether her expertise was recognized. The fourth hurdle was change itself. Medicine was becoming more powerful. Blood transfusion systems improved, antibiotics altered the odds against infection, air evacuation moved wounded patients faster, new specialties expanded. Every advance created fresh responsibilities, more equipment to monitor, more drugs to understand, more severely injured people who might now survive if nursing care held steady. Even ordinary bedside work was physically punishing. Nurses lifted and turned patients without modern-powered beds or mechanical lifting devices. They sterilized and reused equipment that would later become disposable. Paper records had to be written by hand, medications prepared carefully, and changes in a patient's condition noticed without electronic monitors sounding an alarm. A temperature, a pulse, a change in breathing, or a patient's sudden confusion could be the warning system. Observation was not a soft extra. It was critical technology carried in the nurse's own eyes, ears, memory, and judgment. That is the hidden paradox of medical progress. When treatment becomes capable of saving someone, the nurse's workload does not necessarily shrink. Often it becomes more complex. A patient who once would have died quickly may now need days or weeks of exacting care. By the end of the decade, nursing had gained education, visibility and professional standing. The war proved that nurses could lead teams, make decisions under fire, master new technologies, and hold entire systems together. Federal support brought nursing education to women who might never otherwise have afforded it. Military service widened expectations. Activists forced discrimination into public view. But progress came at a price paid in double shifts, exposure, low pay, separation, and lives organized around other people's emergencies. The nurses of the 1940s were not simply angels in white, and calling them heroes can sometimes hide what they were denied. They were skilled workers operating inside institutions that depended on them while resisting fair treatment. Their decade helped build modern nursing because they endured the old system and pushed beyond it. So when we celebrate how far nursing has come, the harder question is this: which burdens from the 1940s have truly disappeared, and which have only been given modern names?